Monday, September 11th, 2023. AGNDD Intellireport topic: Parkinson's disease. Please pardon any visual and informational inaccuracies in this entirely AI-generated Wikipedia-sourced video article.
Parkinson's disease is a neurodegenerative disorder characterized by the accumulation of a misfolded protein in the brain. It presents with movement-related symptoms, but also includes non-motor symptoms and can progress to more severe complications. Parkinson's disease is a neurodegenerative disease characterized by the accumulation of a misfolded protein called alpha-synuclein in the brain. It is the most common form of Parkinsonism and has no identifiable cause. Other Parkinson plus syndromes, such as Lewy body dementia, multiple systems atrophy, progressive supranuclear palsy, and corticobasal syndrome, have similar movement symptoms but different associated symptoms and involve different proteins such as tau. Understanding the presentation timelines and associated symptoms can help differentiate these disorders from idiopathic Parkinson's disease. The most recognizable symptoms of Parkinson's disease are movement-related, including tremors, slow movement, muscle stiffness, and a shuffling gait. However, there are also non-motor symptoms such as autonomic dysfunction, neuropsychiatric problems, sensory issues, and sleep difficulties. Some patients may experience non-motor symptoms before the onset of motor symptoms. As the disease progresses, more severe symptoms like dementia, psychosis, and difficulty swallowing may occur. Dysphagia, or difficulty swallowing, affects over 80% of patients at some point during the course of the disease. Parkinson's disease, PD, is characterized by 4 cardinal motor symptoms: tremor, slowness of movement, bradykinesia, rigidity, and postural instability. Tremor is a common early sign, typically affecting one hand and disappearing during voluntary movement. Bradykinesia leads to difficulties with everyday tasks and impaired simultaneous movements. Rigidity can be uniform or ratcheted and is associated with joint pain. Postural instability leads to impaired balance and frequent falls. Other motor signs include gait and posture disturbances, freezing of gait, a quiet voice, mask-like facial expression, and small handwriting. Parkinson's disease, PD, can cause various neuropsychiatric disturbances encompassing cognitive, mood, behavioral, and thought disorders. Cognitive issues like executive dysfunction are prevalent and can involve challenges in planning, memory, attention, and abstract thinking. Slowed cognitive processing speed and impaired perception of time are also observed. PD patients face an elevated risk of developing dementia, with as many as 78% experiencing Parkinson's disease dementia. Dementia is linked to a reduced quality of life, heightened mortality, and a greater probability of requiring nursing home care. Psychosis is a common symptom in Parkinson's disease, PD, with a prevalence ranging from 26 to 83%. Approximately 50% of individuals with PD experience hallucinations or delusions, which may indicate the onset of dementia. These hallucinations can vary from minor sensations to vivid visual hallucinations and paranoid thoughts. Auditory hallucinations are uncommon in PD and are not typically characterized as voices. Psychosis is believed to be an inherent aspect of the disease itself, but it can also arise as a complication of anti-Parkinson drug treatment. Urinary tract infections and alterations in neurotransmitters or their receptors are believed to contribute to psychosis in PD. Behavior and mood alterations are common in Parkinson's disease, PD, with depression, apathy, and anxiety being the most frequent mood difficulties. Depression affects 20 to 35% of patients and can manifest with symptoms common to the disease. Anxiety has a prevalence of 30 to 40% in PD patients and can be higher during off periods. Apathy and anhedonia, loss of motivation and pleasure, are also common in PD. Impulse control disorders and punding, repetitive behaviors can be medication-related side effects in PD. Gastrointestinal issues in Parkinson's disease include constipation, impaired stomach emptying, excessive saliva production, swallowing impairment, and small intestinal bacterial overgrowth. These symptoms are caused by alpha-synuclein deposits in the digestive tract. Constipation is a common early symptom of Parkinson's and may occur before the diagnosis. These gastrointestinal issues can cause discomfort and may pose a risk to the individual's health. Sleep disorders are common in Parkinson's disease, PD, and can be exacerbated by medications. Symptoms include daytime drowsiness, disturbances in REM sleep, and insomnia. REM behavior disorder may appear before motor or cognitive symptoms. Autonomic nervous system changes can cause orthostatic hypotension, oily skin, excessive sweating, urinary incontinence, and altered sexual function. Perception changes may include impaired smell, vision problems, pain, and tingling. These symptoms can occur years before PD diagnosis. There is no definitive evidence for the proposed risk factors for Parkinson's disease. However, some studies have shown a higher risk in individuals exposed to pesticides and a lower risk in smokers. There is also a potential connection between Parkinson's disease and Helicobacter pylori infection, which can hinder the absorption of certain medications like levodopa. Research suggests that Parkinson's disease, PD, is caused by a combination of genetic and environmental factors. Approximately 15% of individuals with PD have a family history of the disease, and 5 to 10% have specific gene mutations. These gene mutations, such as SNCA, LRRK2, and GBA, increase the risk of developing PD. Alpha-synuclein, a protein encoded by the SNCA gene, plays a role in the formation of Lewy bodies, which are characteristic of PD. Mutations in genes involved in lysosomal function may also contribute to PD. Exposure to pesticides, head injury, and not drinking caffeinated beverages are associated with a slightly increased risk of Parkinson's disease, or PD. Certain toxins and medical drugs can also cause Parkinsonism, a condition with similar symptoms to PD. Low levels of urate in the blood are linked to a higher risk of PD. Other causes of Parkinsonism include infections, metabolic disorders, and neurodegenerative disorders. Dementia with Lewy bodies is a related condition to PD, and vascular Parkinsonism is characterized by PD symptoms combined with vascular events. Differentiation between these conditions can be made through examination, history evaluation, and imaging. Parkinson's disease, PD, is characterized by cell death in the brain's basal ganglia, particularly in the substantia nigra pars compacta. This leads to the misfolding and clumping of alpha-synuclein, which damages cells and forms Lewy bodies. The loss of neurons is accompanied by the death of astrocytes and an increase in microglia. PD affects 5 major pathways in the brain, causing movement, attention, and learning-related symptoms. The motor circuit influenced by dopamine is the most extensively studied. Dopamine depletion in PD leads to reduced motor output, while excessive dopamine activity from treatment can cause dyskinesias. Brain cell death in Parkinson's disease is caused by the abnormal accumulation of the protein alpha-synuclein bound to ubiquitin in damaged cells. This protein forms inclusions called Lewy bodies, which first appear in certain brain regions and then spread to others as the disease progresses. Lewy bodies may be protective against cell death, while other forms of alpha-synuclein may be toxic. Dysfunction in proteasomal and lysosomal systems, reduced mitochondrial activity, and iron accumulation in the substantia nigra are also involved in the disease. The neuroimmune interaction plays a significant role in the pathology of Parkinson's disease, PD. There is a connection between PD and autoimmune disorders with shared genetic variations and molecular pathways. Autoimmune diseases can increase the risk of developing PD. Herpes virus infections can trigger autoimmune reactions to alpha-synuclein, a protein associated with PD. Microglia, immune cells in the brain, can be activated by alpha-synuclein, leading to inflammation. Astrocytes, another type of brain cell, lose their neuroprotective function in PD. Peripheral immune cells, such as monocytes and T cells, also contribute to PD pathology. Inflammation and gut-brain axis dysfunction are implicated in PD development. Further research is needed to fully understand the immune-related mechanisms underlying PD. The initial assessment of Parkinson's disease, PD, is typically based on medical history and neurological examination. Motor symptoms are assessed using clinical diagnostic criteria, and the presence of Lewy bodies in the midbrain on autopsy is considered final proof of PD. However, there are multiple causes of Parkinsonism or similar diseases that need to be ruled out. Parkinson plus syndromes must also be considered and appropriately ruled out. Diagnostic criteria have been created to standardize the diagnostic process, and the accuracy of PD diagnoses ranges from 73.8% to 83.9%. Computed tomography (CT) scans are usually normal in people with Parkinson's disease, PD, but magnetic resonance imaging (MRI) has become more accurate in diagnosing the disease. Iron-sensitive T2 star and susceptibility-weighted imaging sequences can show the absence of a characteristic pattern in the substantia nigra, which is highly sensitive and specific for PD. Neuromelanin MRI can also discriminate between individuals with PD and healthy subjects. Diffusion MRI shows potential in distinguishing between PD and Parkinson plus syndromes. Positron emission tomography and single photon emission computed tomography scans can measure dopamine transporter activity in the basal ganglia, which can help diagnose PD. Iodine 123 meta-iodobenzylguanidine myocardial scintigraphy can locate denervation of heart muscles supporting a PD diagnosis. Secondary Parkinsonism refers to Parkinsonism caused by factors other than Parkinson's disease itself. It can be differentiated from Parkinson's disease through careful history, physical examination, and appropriate imaging. Parkinson plus syndrome includes multiple diseases such as corticobasal syndrome, multiple system atrophy, progressive supranuclear palsy, and dementia with Lewy bodies. Differential diagnosis involves considering the sequential onset of specific symptoms, disease progression, and response to treatment. Other conditions that can mimic Parkinson's disease include essential tremor, multiple system atrophy, and progressive supranuclear palsy. Exercise in middle age may reduce the risk of Parkinson's disease, PD, later in life. Caffeine intake, particularly from coffee, may also be protective against PD. Antioxidants like vitamin C and E have been suggested to protect against PD, but results have been inconsistent. The effects of fat and fatty acids on PD risk are unclear. The use of non-steroidal anti-inflammatory drugs, NSAIDs, and calcium channel blockers may have a protective effect. Some studies have shown a decreased risk of PD with the use of ibuprofen. Parkinson's disease has no known cure, but medications, surgery, and physical treatment can provide relief and improve quality of life. The main drugs used are levodopa, dopamine agonists, and MAO-B inhibitors. Treatment strategies vary depending on the stage of the disease. In later stages, surgery and other interventions may be necessary. Cognitive training has not been proven to be beneficial for Parkinson's disease, dementia, or mild cognitive impairment, according to a 2020 Cochrane review. Levodopa is the primary medication used to treat Parkinson's disease. It works by increasing dopamine levels in the brain. However, only a small amount of levodopa actually reaches the brain, with the rest being converted to dopamine in other parts of the body, leading to side effects. To address this, dopa decarboxylase inhibitors like carbidopa and benserazide are often taken alongside levodopa to reduce side effects and improve its effectiveness. Prolonged use of levodopa can lead to complications such as involuntary movements and fluctuations in medication response. Lower doses of levodopa may help reduce these complications. Inhaled levodopa can be used when oral medication is no longer effective. During the course of Parkinson's disease, PD, some individuals may experience a wearing-off phenomenon where symptoms recur before their next dose of levodopa. Catechol-O-methyltransferase, COMT inhibitors, can help by preventing the degradation of levodopa before it reaches the brain. 3 COMT inhibitors used to treat PD are opicapone, entacapone, and tolcapone. Tolcapone may cause liver damage and requires monitoring, while entacapone and opicapone have minimal impact on liver function. Entacapone can be used alone or in combination with carbidopa and levodopa, while opicapone is a once-daily COMT inhibitor. Dopamine agonists are drugs that bind to dopamine receptors in the brain and have similar effects to levodopa. They are used as a complementary therapy to levodopa or as a first-line treatment for the motor symptoms of Parkinson's disease, PD. They can delay the initiation of levodopa therapy and its complications. Common dopamine agonists include bromocriptine, pergolide, pramipexole, ropinirole, pyribydyl, cabergoline, apomorphine, and lisuride. While they are less effective than levodopa, they can effectively manage symptoms in the early stages of treatment. However, they can cause side effects such as drowsiness, hallucinations, insomnia, nausea, and constipation. They have also been associated with impulse control disorders. Apomorphine is used to reduce off periods and dyskinesia in late-stage PD, but it can cause confusion and hallucinations. Skin patches containing lisuride and rotigotine can be used in the initial stages of PD or to control off states in advanced stages. Ergot-derived dopamine agonists should only be considered as adjunct therapy to levodopa due to an increased risk of cardiac fibrosis. MAO-B inhibitors like safenamide, selegiline, and rasagiline enhance dopamine levels in the basal ganglia by inhibiting monoamine oxidase B. They can alleviate motor symptoms of Parkinson's disease either alone or with levodopa. Selegiline may also postpone the requirement for levodopa and potentially decelerate disease progression. Usual side effects consist of nausea, dizziness, insomnia, sleepiness, and orthostatic hypotension. MAO-B inhibitors can raise serotonin levels and potentially induce serotonin syndrome. Amantadine may be helpful in treating motor symptoms, but there is limited evidence to support its use. Anticholinergics should not be used for dyskinesia or motor fluctuations, but they may be considered for drooling. Various pharmaceutical treatments can address symptoms beyond motor function, such as quetiapine or clozapine for psychosis, cholinesterase inhibitors or memantine for dementia, and modafinil for excessive daytime sleepiness. Pimavanserin was approved in 2016 for managing Parkinson's disease psychosis. Doxepin and racegline may reduce physical fatigue in Parkinson's disease. Surgery for Parkinson's disease, PD, is now less common due to the effectiveness of levodopa. However, advancements in surgical techniques have made it a viable option for those with advanced PD who do not respond well to medication. There are two main types of surgery for PD: lesional and deep brain stimulation, DBS. DBS involves implanting a neurostimulator that sends electrical impulses to specific parts of the brain. DBS is recommended for those with motor fluctuations and tremors that are not controlled by medication. Different areas of the brain can be targeted for DBS with varying effects on motor function. Overall, DBS can lead to a 30 to 60% improvement in motor scores. Exercise programs, including physical therapy, can be beneficial for individuals with Parkinson's disease, PD. Regular physical exercise can improve mobility, flexibility, strength, gait speed, and quality of life. Supervised exercise programs with a physiotherapist have shown more improvements in motor symptoms, mental and emotional functions, daily living activities, and quality of life compared to self-supervised programs at home. Relaxation techniques, gait training strategies, strengthening exercises, and speech therapy, such as the Lee Silverman voice treatment, may also be effective interventions for individuals with PD. Occupational therapy may improve motor skills and quality of life, but more research is needed. Palliative care aims to improve the quality of life for patients with Parkinson's disease and their families by providing relief from symptoms and addressing emotional concerns. It is recommended to involve palliative care earlier in the disease course. Palliative care specialists can help with physical symptoms, emotional support, and guide patients in making decisions about their care. Nutritional considerations such as a balanced diet and managing swallowing difficulties are also important in managing Parkinson's disease. Additionally, the timing and interaction of levodopa and protein intake should be carefully managed. Parkinson's disease, PD, is a progressive condition that worsens over time. The Unified Parkinson's Disease Rating Scale, UPDRS, and the modified version, MDS-UPDARS, are commonly used to measure the severity of the disease. The Hone and Yahr scale is an older method that defines 5 stages of progression. Motor symptoms tend to progress more aggressively in the early stages and slower later on. The average time for individuals to lose independent ambulation is around 8 years without treatment. Medications such as levodopa can improve motor symptoms and delay dependency on caregivers. However, predicting the course of the disease for an individual is challenging. Age is a factor that can influence disease progression, with younger individuals experiencing a faster decline in motor function and older individuals being more prone to cognitive impairment. Disability in PD is mainly related to non-motor symptoms, and therapies exist to address these symptoms. However, disability and disease progression are independent of each other. Disability initially stems from motor symptoms but later becomes more related to uncontrollable motor issues and levodopa-induced complications. After 10 years, most people with PD experience autonomic disturbances, sleep problems, mood alterations, and cognitive decline, which significantly increase disability. The life expectancy of individuals with PD is reduced, with mortality rates being twice as high as those of unaffected individuals. Cognitive decline, old age at onset, advanced disease stage, and swallowing problems are risk factors for mortality. Tremor-dominant PD may have a better prognosis in terms of survival. Aspiration pneumonia is more common in individuals with PD compared to the general population. In 2016, PD caused approximately 211,000 deaths globally, with a significant increase since 1990. The overall death rate also rose during that time. Parkinson's disease, PD, is the second most common neurodegenerative disorder globally, affecting around 7 million people worldwide and 1 million in the United States. The prevalence of PD is about 0.3% in industrialized countries, with higher rates in the elderly population. The mean age of onset is around 60 years, but a small percentage of cases occur in younger individuals. PD is more common in males than females, and its prevalence may vary among different ethnicities. The incidence of PD has been stable in Estonia but is increasing in China, where it is projected to have nearly half of the global PD population by 2030. By 2040, the number of PD patients is expected to reach approximately 14 million, leading to concerns about a Parkinson's pandemic. Early sources, including ancient texts and medical treatises, describe symptoms resembling Parkinson's disease, PD. In the 17th and 18th centuries, several medical professionals wrote about elements of the disease. James Parkinson's essay in 1817 provided a detailed description of PD symptoms. Jean-Martin Charcot made significant contributions to understanding the disease in the late 19th century. In the early 20th century, microscopic particles called Lewy bodies were discovered in affected brains. The underlying biochemical changes in the brain were identified in the 1950s. The arrival of l-dopa in the 1960s revolutionized PD treatment, and deep brain stimulation emerged as a potential therapy in the late 1980s. The costs of Parkinson's disease, PD, to society are significant, but calculating precise figures is challenging due to research limitations and country differences. Inpatient care and nursing homes contribute the most to direct costs, while medication costs are relatively lower. Indirect costs are high due to decreased productivity and the strain on caregivers. A study estimated the economic burden of PD in the U.S. to be $51.9 billion in 2017, with projected costs exceeding $79 billion by 2037. Interventions to reduce PD incidence and alleviate symptoms are needed to lessen the future economic burden. World Parkinson's Day is celebrated on April 11th, the birthday of James Parkinson. The red tulip is the symbol of the disease, representing the James Parkinson tulip cultivar. Advocacy organizations such as the National Parkinson Foundation, Parkinson's Disease Foundation, American Parkinson Disease Association, and European Parkinson's Disease Association provide support, research funding, and education programs for those affected by Parkinson's disease. Actor Michael J. Fox was diagnosed with Parkinson's disease at the age of 29 and has used his platform to raise awareness about the condition. He has portrayed characters with Parkinson's on television and written autobiographies about his experience. Fox has also appeared before Congress to advocate for Parkinson's research. The Michael J. Fox Foundation, which he founded, aims to find a cure for the disease. Other notable figures with Parkinson's include cyclist Davis Finney, boxer Muhammad Ali, and the late actor Robin Williams, who was also diagnosed with Lewy body disease. As of 2022, there are no approved disease-modifying drugs for Parkinson's disease. Research is focused on finding new animal models, exploring gene therapy and stem cell transplants, and studying neuroprotective agents. There is also a focus on identifying prodromal biomarkers for early diagnosis. The role of the gut-brain axis and gut flora in Parkinson's is recognized, but the mechanism behind gastrointestinal symptoms is still unclear. Gene therapy involves using a non-infectious virus to deliver genetic material into the brain. This can include growth factors and enzymes to prevent damage and improve function. However, these approaches have mostly failed in Phase 2 clinical trials. One promising approach involved delivering the enzyme GAD, which improved motor function but was not as effective as deep brain stimulation. Follow-up studies have shown persistent improvement in the same group of patients. Overall, safety concerns have not been reported. PD01A, a vaccine developed by Apheris, has entered clinical trials and has shown promising safety and tolerability in a Phase 1 report. The vaccine aims to activate the immune system to target and destroy alpha-synuclein, a protein associated with Parkinson's disease. Similarly, PRX002/RG7935, an antibody, has also shown preliminary safety evidence in Stage 1 trials, supporting its progression to Stage 2 trials. These developments offer potential advancements in the treatment of Parkinson's disease. Since the 1980s, various tissues such as fetal, porcine, carotid, or retinal tissues have been used in cell transplants to replace dopamine-producing cells lost in Parkinson's disease. However, induced pluripotent stem cell-derived dopaminergic neurons are now considered a more viable option. While early evidence showed benefits, long-term effects are still unknown. Excess dopamine release from transplanted tissue has also led to dyskinesia. In 2020, a clinical trial successfully transplanted induced pluripotent stem cells into a Parkinson's patient's brain, marking a significant milestone. Istradifilene, an antagonist of adenosine receptors, specifically A2A, has shown promise as a potential drug for Parkinson's disease. It has been approved for medical use in the United States in 2019 and is used as an add-on treatment to the levodopa-carbidopa regime. This medication aims to provide additional benefits in managing the symptoms of Parkinson's disease. In conclusion, Parkinson's disease is a complex neurodegenerative disorder with a range of symptoms that go beyond just movement-related issues. Understanding these symptoms can aid in accurate diagnosis and management of the disease.
Thank you for watching this AGNDD Intellireport. Like, subscribe, and click the bell button to get notified during new uploads. And make sure to tune in next time. Stay safe and healthy. Cheers.